Hello, everyone. Welcome to today's webinar, Outcomes Not Ours. One Size Doesn't Fit All, our second webinar in our series with Catalight. I'm Chris Larson, reporter for Behavioral Health Business. I've been covering the healthcare sector since 2016, and I'm excited to be moderating today's conversation. During this webinar, we'll discuss Catalight's perspective that outcomes, rather than hours of therapy, are the true measure of quality in the successful treatment of autism spectrum disorder, also known as ASD. We'll save 15 minutes or so at the end of today's webinar for audience questions, so please enter your questions into the Q&A section of your Zoom window during the webinar. Our panel will answer as many as possible after the discussion. We're also putting a link in the chat to a post-webinar survey. Please take just 1 minute after our webinar to share your feedback through the survey. I also wanted to start off with a special thank you to Catalight and the Treatment and Research Institute for Autism Spectrum Disorders, or TRIAD, at Vanderbilt University for partnering with us for today's webinar. Today, we are joined by Dr. Lindsey Sneed, Vice President of Clinical Excellence at Catalight, and Kathleen Simcoe, Co-Director of Early Intervention at TRIAD. Lindsey, Kathleen, can you tell us more about your background and respective roles? Lindsey, let's go ahead and start with you.
Yeah, thanks, Chris. I'm really excited to be here with you and with my colleague, Kathleen. So I am a clinical psychologist and a board-certified behavior analyst. I've been in the realm of behavioral health treatment, working with individuals with intellectual and developmental disabilities for 15 plus years. Of those years, I've been with Catalight for 11. I'm the Vice President of Clinical Excellence. So in my role, I'm really overseeing providing clinical oversight and then doing research leadership for the organization. My areas of specialty really are in the realm of autism spectrum disorder, in diagnostics, intervention, and research.
I got you, Kathleen. Let's go ahead and go to you for your intro.
Great. Thanks, Chris. Like Lindsey said, I'm excited to be here today with all of you. I am Kathleen Simcoe, the co-director of early intervention here at Vanderbilt Triad, which is the Autism Institute at the Vanderbilt Kennedy Center. In my current role, I co-lead a large grant that provides services throughout our state. And I also provide some care in a low intensity model, along with doing some research and conducting some school-based services as well. I have also been in the field for about 15 years, since 2007, working in ABA and education. My roles have included roles as a clinical director, a behavior analyst, and a classroom teacher. I've been at Triad for the last 8.5 years. And throughout my work, I think I've always really been focused on empowering families, providers, and educators to kind of maximize their professional skills and enable the learners they're caring for to meet their goals and fulfill their dreams. So excited to chat more today.
Awesome. Great baseline to help us get started, guys. Let's go ahead and dive into the question portion of our discussion. So first, why are outcomes a better measure of quality in autism care rather than hours for quality of care? Lindsey, let's go ahead and have you start us off.
Yeah, well, one thing I think is important to note is that there has been a long-held belief and understanding that quantity of ABA hours actually does equate to quality ABA treatment. But more robust research that's been coming out recently, really in the last 7 years, has actually shown that hours are not a predictor of treatment outcome, that there's other areas that actually we can use as predictors of treatment outcome. So when we go back to the 1987 Lobaugh study, which was monumental for our field, really it created a space and a place for people with intellectual and developmental disabilities to show that interventions can make a really positive impact on individuals' lives. And in that original study, many of the participants received 30 to 40 hours a week. But I think it's important to note that in that original study, there was 19 children in the intervention group. 9 were considered like best outcome, did really well in the intervention, and 10 did not do as well in the intervention. So we're looking at about 50% of the population in that original study that didn't do as well. Then research in the 90s was really looking at, how can we implement this really effective intervention with young autistic children? demonstrating that time and time again, it is really, really effective. So, that is such great news for the population that we work with. And the other great news is, like, originally back in the early 90s, early 2000s, there was really that belief that 30 to 40 hours a week of intervention was necessary. But recent studies are showing that it's not. So in 2015, Tristram Smith and colleagues, they evaluated what are predictors in treatment outcome for applied behavior analysis for young autistic children. And their results demonstrated that hours actually had no predictive value. These authors went on to state that despite the long-held belief that hours are a big component to treatment outcome, that perhaps they actually aren't. Perhaps there's other things that are really important to look at, including like the child's cognitive ability, social skills, all of that. And then in 2017, another study came out by Tara and colleagues, again, evaluating predictors in treatment outcome. The number one predictor for treatment outcome in their study was baseline cognitive ability of the children included in the study. So those with higher cognitive baseline ability actually went on to make greater progress than those who had a lower baseline cognitive ability. And then the other area that they looked at was age of treatment start. So we all know that early intervention is so important. And consistently, the earlier that we can start into intervention, the better the outcome or potential outcome. But their study also found that hours were not predictive of treatment. And then another study came out in 2021 by Rogers and colleagues, really evaluating 15 hours versus 25 hours a week of intervention for young autistic children receiving either naturalistic developmental behavior intervention or more discrete trial training ABA. And their results demonstrated that there was actually no difference in the treatment groups. So both groups, regardless of treatment type and regardless of hours, made significant progress. So 15 hours was commensurate with 25 hours. And more studies are coming out revealing this fact. And so I think it's really important for us to look at what are things that do lead to positive outcomes and how do we consistently measure outcomes for our population. Right now, we don't have one consistent measure that is agreed upon for behavioral health treatment for young autistic children or autistic people in general. So we really need to be looking at what are outcomes that we can be looking at, which can include a plethora of them, including adaptive skills, goals. There's been a big call recently to include the whole family as part of the treatment outcomes, to be evaluating how treatment is impacting the caregivers, how treatment is impacting siblings. And there's various measures that we can use to see how that is going. So it's really important for us to be evaluating outcomes ongoing, to evaluate whether or not treatment actually is, whatever the respective treatment is really effective.
I gotcha. And Kathleen, let's go ahead and bring you into the conversation. So why are outcomes a better measure of quality in autism rather than hours?
I think that Lindsey made some great points there about kind of all of the reasons, kind of how we got here with hours, and also why sometimes outcomes may be a better predictor of quality. I think, we've all probably seen examples of patients that get hours and hours a week of care, and yet don't make much progress or receive really limited benefit from that therapy. I've also seen situations, right, maybe in a crisis situation or really high levels of dangerous behavior, where that really intensive kind of piece of hours is needed, maybe for a kind of a brief period of time. So I think what kind of differentiates both of those situations, right, is looking at those outcomes. What's the impact on the learner in this situation? What's the impact on the family members and others, like Lindsey said? So I think, keeping kind of that learner or that client at the focus of that and thinking about what those outcomes look like rather than focusing on a specific targeted number of hours or a minimum number of hours is really key. Because that, I think what we've learned from all the research that Lindsey highlighted is that hours can certainly impact outcome, but they're not, key to it probably. So we can have great outcomes with limited hours. And in some situations you may need more, but those cases are kind of limited in special circumstances. I think thinking about those outcomes and what the goal is that you're trying to meet, often our goal is to improve an individual's participation in their, their family, their community, their kind of natural settings. So we want to make sure we're allowing them to meet those goals. And part of that is going to require letting them participate in those settings as well. And therapy doesn't necessarily always preclude those, but it can pose challenges. There are only so many hours in the day. So helping our learners think through that can be really helpful.
I gotcha. And Kathleen, we're going to stay with you for the first answer on this next question. Outcomes are generally the focus for gauging success in physical healthcare. Why has a focus been on hours rather than measurable outcomes been the case with ASD? We talked a little bit about some of the history that took us there with the research background, but at least as this is applied, why was there this focus on hours and application?
It's a great question. And like you just mentioned, I think, some of that initial research probably plays a role in that. And just, I always think back to saying my grandmother used to say, which is you can only make the best decision you can with the information available to you, right? So as our information has changed, we have needed to change what we're doing. And so I think, everyone that started out with this was probably very well intentioned with their recommendations of hours. But as we get new information, we need to continue to update our processes and our plans. Another thing that I think probably has made an impact is that that the diagnosis of autism is based on behavioral observations, not a physical marker. We can't draw a lab or measure one specific number to kind of determine where an individual falls on that spectrum. And it's not like blood sugar or something like that, where there's a really clear kind of, green zone and red zone or something. But because of that, I think sometimes the desired outcome wasn't always clear, right? Were we just trying to improve functioning? Were we trying, there was a period of time, I think particularly in the 90s and early 2000s, where folks were really looking for a cure for autism, right? We've really shifted away from that in the last 10 or so years. But as that has shifted, some of our markers of what that kind of successful outcome has looked like has changed, and so we've needed to shift that. So I think a lot of the focus on hours probably came from those initial studies, but also in absence of a better way to measure, that gave us a way to quantify something for a large number of people and a growing number of people in a way that was consistent, right? Some things were highly manualized, and that was a way to kind of standardize it. So I think this was all probably in a driver to ensure that we were trying to provide quality care as we were still learning this, and it's still evolving today. It's not like we have all the answers to the questions, right? That's why there's always new research to read and keep up with.
I gotcha. And Lindsey, a thought to add?
Yeah, I mean, I agree with everything Kathleen just said. And I think one thing that's really important is like the ever-evolving research that's coming out, and consistently the research in the last 10 years or so is demonstrating hours aren't predictive. Hours, like there is definitely a need for an amount of hours, right? We can't just like provide 0 hours and expect a change to happen. But there is some sort of quantity there. I don't think we quite know what it is. It's definitely 15 hours and under, if we can generalize the Rogers study. In general cases, like Kathleen said, there's going to be specific cases where we might need to provide more intensive care for a shorter duration of time. But what I really think about is evidence-based practice. And with evidence-based practice, there's 3 components that we evaluate. The first component that we evaluate is the best available research. The next component is the clinician or the person who's providing the intervention, their training and expertise. And then the third area that we look at is the individuals who's receiving that care, what their priority and preferences are. So when we think about like that first area, the research, the best available research right now is showing that hours aren't predictive. And so I think it's difficult to say that make a blanket statement that everyone needs like this high intense amount of hours, where consistently we just see that that's not the case. And the research is going in the direction of that we can make big positive changes in individuals' lives with interventions based on applied behavior analysis with less hours.
I gotcha. So let's go ahead and move on to the next topic in our conversation. So why are we seeing a shift in the dialogue today? And are there barriers to moving towards this quality outcomes approach versus quantity approach? Kathleen, let's go ahead and start off with you.
Great. Thanks, Chris. I think this is always an interesting question. This field is ever evolving. And so I think, that's part of it. We've already hit on kind of as research emerges, things shifts are necessary, right? I also think that, again, our understanding of autism has shifted over time. We're getting more and more input from autistic self-advocates that are highlighting some of the potential harms of extensive time spent in therapy, also getting input about some of the benefits that they have received from therapy over the years. But I think as our understanding of this as a whole picture evolves, we're seeing some shifts in the dialogue today. So I think we're seeing just shifts in kind of what people are interested in terms of seeking therapy, right? So we've got more data available. We've got kind of shifts in our understanding of autism, additional feedback from kind of previous participants in ABA and what that may look like. In terms of barriers, I think, there are a lot of ABA providers. There are a lot of payers for this model. So, it's kind of like turning the Titanic around, right? We're headed in one direction, and we may not need to turn all the way around, but, even small course adjustments can take some time. And there's a lot of different kind of consumers and parties here that all need to think about what makes a meaningful and sustainable system for them and make those shifts. So we also want to be careful, right? We know ABA is a really effective science. So we don't want to just say, never mind, no time is needed. It doesn't matter how much ABA you do. I don't think that's what either Lindsey or I is saying. We're saying that we need to be mindful of kind of not just assuming that more is better, right? Sometimes more is not better. And so we want to, use our science really effectively and use, good data analysis skills and other things to look at what outcomes might point to kind of success and really evaluate that treatment effectiveness and set up efficient and effective intervention plans where we can.
I got you. And Lindsey, let's bring you into the conversation on this topic. So why are we seeing the shift in dialogue today, and what are the barriers to getting towards a quality versus quantity approach?
Yeah, I think the shift in dialogue is really coming out of a few areas, and I'm probably not even stating all of them. But I think, again, speaking to the best available research, what we're seeing in the most recent research is really, really important for us to evaluate. Going back to what Kathleen said about autistic self-advocates, talking about their experiences, what they want to work on, what previous goals and applied behavior analysis could have been. I'm not saying they always were, but was in trying to change the individual, change the human, right? And there's been a shift of more acceptance of who the person is and wanting to ensure that we're accepting the person for who they are. And not that everyone was implementing applied behavior analysis that was trying to change individuals. But whether or not, from my perspective, whether or not that was true for the artistic self-advocates, that was their truth, that was their experience. So it's so important for us to be listening to those experiences and learn from them and make changes based off them. I think another barrier is the fee-for-service model that most insurance carriers use, where, we provide service, we get a fee for service for those things. So I think another area that's coming out that is potentially shifting is this idea is looking more at value-based care. So yeah.
I gotcha. So a couple things that we've touched on already leading into our next question. We talked about an inherent challenge, maybe more so in trying to measure outcomes when it comes to treating autism spectrum disorders, especially in comparison to physical healthcare and physical medicine. So then how does one measure outcomes in autism care given this inherent difficulty, but also given the heterogeneous and diverse nature of people who come to ABA or who have conditions that are on the spectrum? Lindsey, let's go ahead and going to keep with you on this one.
Yeah. This is such a great question. And this is a question as at Catalight we've been asking ourselves a lot and trying to understand. Excuse me, sorry. So through the years, there's been multiple different outcome measures that we can look at. The Vineland is a valid and reliable subjective assessment that looks at adaptive skills for individuals, and it's been used with our population, validated with our population. But of course, there are inherent things about the Vineland that aren't as great using it. There's other things like measuring parental stress, like how is outcomes affecting parental stress. We can look at goal attainment. At Catalight, we use the goal attainment scale as our standardized tool for implementing goal progress. So there are a lot of different options. I'm not speaking to all of them by any means, but one thing that we've been really thinking about and trying to think about and implement is looking at the individual's well-being. Can well-being be the global outcome measure for this population when we're implementing various different types of interventions, whatever it may be? When I think about cognitive behavior therapy with youth and adults with autism who are trying to work on their mental health needs, ultimately we want to lead to things that are, going to improve their overall well-being. So interventions in applied behavior analysis, I don't think they need to be any different. We can be evaluating the individual's well-being. Is everything that we're doing contributing to positive well-being? If we're focusing on adaptive behavior, ultimately that should be with the goal of improving the individual's well-being. If we're working on disruptive behavior, ultimately we should be improving the individual and the family's well-being. So everything that we do should measure up to this idea of, are we improving the individual's well-being? One example that I think is really important to talk about is for a long time, interventions based in applied behavior analysis and other types of interventions, specifically for the autistic population, there had been a lot of focus on reducing restrictive and repetitive behaviors that were not dangerous to the individual. But as we've learned more about RRBs, or self-stimulatory behavior, again, that's not dangerous. We found that RRBs can actually be a self-soothing mechanism, a coping mechanism, something that's really valuable, inherently valuable to the person. And so if we focus on trying to reduce RRBs because it's a little bit different, or it inhibits other areas of socialization, ultimately, there's potential that we're reducing the individual's well-being by trying to reduce those behaviors, because we're taking away effective coping skills from them. So really thinking about so how can we change our model so that we're really championing, I can't say that word right now, apparently, the individual, what's important to them, while also helping them focus on the areas that are really important to them to focus on, rather than assuming that we know what we should focus on.
I gotcha. And Kathleen, let's shift to you. So the question is about, how does one measure outcomes in autism care?
So I think Lindsey made a lot of good points there. And I think, there are kind of a variety of things. I don't think there is now, and I don't know that it's attainable that there ever will be one kind of clear, we should always use this one tool or this one assessment, right? Because of the kind of diversity of people and participants that we have in this therapy. I love the idea of thinking about kind of individual and family well-being. I think that's really important. In some kind of related work, I have some colleagues here that are doing a lot of work in terms of thinking about social validity to treatment, assent to participate. Our children, if given the choice, will they choose to engage in therapy, and kind of enhanced choice models that are emerging to think about allowing the learner to determine kind of when and how they engage with that therapy. I think one of the things we've learned from that is that often, given the right circumstances, learners will choose to engage with therapy the vast majority of the time if the goals are meaningful to them and the outcomes are meaningful to them, and the therapy is provided and conducted in a way, that builds that buy-in, and, kind of an encouraging and individualized manner. So I think, looking at things, some kind of non-traditional measures there, like buy-in or assent for participating, as well as looking at social validity data for, the learner that is participating in the therapy, family members, if you're in a school or something like that, looking at educator kind of social validity as well, and not just looking at it at the end of the intervention, but looking at it throughout the intervention and kind of being really intentional about setting up systematic ways to collect that at different time points where you can still adjust, right? If you're getting feedback that suggests that something is not working, where you can adjust rather than saying, at the end of a year of treatment, oh, maybe we missed the mark there, and doing it differently the next time. So I think there's a lot of options.
I gotcha. And within those options, are there, benefits for both the individual and their families? Hey, Kathleen, let's go and stay with you.
Sure, I think so. I think it's pretty easy. I don't think it's a big leap to suggest that by focusing on kind of social validity, family well-being, individual well-being, these things, that's likely going to benefit individuals and their families, right? I think in our own personal lives, we could all agree that, when we focus on our own well-being, that often results in better well-being. And I think, there may be some other measures there. Caregiver stress, parental stress has certainly been studied. And we know that sometimes having a child with autism is stressful for families, but we also know that different forms of intervention may improve that stress more or more quickly or with longer impacts. Some of that also varies by other family factor, right? And so again, kind of thinking about, I think it's an outcomes-based approach, essentially, right? Looking at some of those things and thinking about stress and other factors there. Sometimes cost is a piece of those stressors for families. And so thinking about both cost and access to care, right? If we are less focused on making sure that everyone is meeting a minimum number of hours and more focused on aligning our treatment and intervention with outcomes that are meaningful to that family, if that results in reduced hours, that can free up providers to see families sooner, or to see, maybe a different number of families with a different kind of allocation. It can also lower the costs for families, things like that. And sometimes I think just focusing on outcomes rather than hours often can make services more accessible because we're being a little bit more creative, right? So part of my work is really focused on access for rural and underserved populations. And that includes a lot of work via telehealth. Telehealth models tend not to focus on high hours dosage, right? Because sitting in front of a screen for a long time is almost never beneficial, particularly for a younger child. But we can focus on some other markers there and still get great outcomes. And so sometimes I think by focusing more on outcomes, we may lead ourselves towards some creative kind of innovations that could improve care for lots of folks that aren't getting care right now.
I gotcha. And Lindsay, do you have a thought to share here?
I like just to emphasize more about the importance of looking at outcomes is we see that in behavioral parent-mediated interventions, like there's more literature coming out about the effectiveness of parent-mediated interventions, particularly for the IDD population. Benefits of those being that the caregivers are taught how to implement the skills and then can implement those skills with their children. And what we see in parent-mediated interventions is benefits for the child. We see positive outcomes for the child, and then we're also seeing positive outcomes for the parent. This is kind of speaking to what Kathleen was saying, where the children are learning new skills, new communication skills, social skills, adaptive skills. Simultaneously, we're increasing parental competence and their own ability to effectively parent their child, which studies have shown is also leading to reduced parental stress because of their competence is increasing. So if we can be, like Kathleen said, more creative about how we're looking at autism care, we can actually see, more outcomes, greater benefit for the whole family. Again, emphasizing that more recently, there's been a call for more inclusion of the whole family in the intervention model, particularly with if there is a higher hours needed, how do we ensure that we're sustaining it within the whole family? An individual can receive 30 hours a week of an intervention based on applied behavior analysis, but unless the family unit, whatever that family unit looks like, knows how to also implement those things, some things can be lost on the individual because it's not being carried over in their natural environment. Again, not that that's always the case, but those are just some important factors for us to be thinking about and looking at. And it also is by thinking more creatively and like looking at individual needs, individual characteristics, and also honestly what the families want, what's of value to them, what's valuable for their family unit. We can also create more equitable access to care. We know that there are, really long wait lists. And if we can be more creative about that, we can actually serve more individuals than we currently are.
I gotcha. Now moving on to our next topic of conversation, how can the healthcare industry, including providers and payers together, adapt to a model where outcomes play a central role in assessing the success of care? Kathleen, let's go ahead and start with you.
Great. Thanks, Chris. I think, we've already alluded to some pieces of this, right? So thinking about kind of the role that everybody plays here in terms of providers and payers, I think there may be some pros to thinking about outcomes over this. And I think it's going to be important to collaborate, right? I think providers have a lot of knowledge about the types of things that are often tied to good outcomes and where those quality kind of pieces may come in. Payers have a lot to say, obviously, in terms of the value that's provided. So we really want to hit kind of an ideal spot there, right, where we're providing a good value, but also, maximizing those outcomes and increasing access to care as much as we can. I think the outcome measures, again, probably need to not be too one size fits all. Often I think, some of the research we've seen, the Vineland, for example, which has a lot of domains and is great, but as you get to kind of the lower end and the higher end of the age kind of piece of that, sometimes that doesn't show progress well for certain learners. And we want to be careful here too, that we don't end up with a model where patients that are going to make slower progress lose their access to care, right? So if we have a patient maybe that makes really meaningful progress in reducing a dangerous behavior, but doesn't make large gains in developmental skills, that's maybe just as valuable as a different patient who makes large gains in functional communication, but wasn't really demonstrating any dangerous behavior that needed to be shifted there. And so thinking about, if you score those two patients on the same scale, they're going to potentially look different depending on the scale. But those are both probably great outcomes that families and providers and payers would all agree are going to lead to better long-term outcomes for that individual. So we want to think about kind of how can we adapt to a model where the outcome is important, but it isn't just a one-size-fits-all approach. I think similar to the challenge with hours, when we focus on kind of one piece, we can end up missing parts that are important to the equation. So kind of customizing those outcome measures, thinking about patient profile and goals, doing some different things like that.
Okay, and Lindsey, let's transition to you.
Yeah, as Kathleen was talking, something that was coming up for me particularly when thinking about like dangerous behavior or disruptive behavior, or if that's, what the primary area of concern is, or if it's communication for a young child, maybe it's a lot of different things. And what comes up for me is thinking about like, what's the reason for the referral? What's the reason why the individual or the family is seeking out behavioral health treatment? Because that can really provide us a lot of insight as to what a priority is. So we have a lot of clients who come in where the family's main priority is actually reducing a disruptive or dangerous behavior. So in that case, like the outcome measure, right, should really be like, are we reducing that dangerous behavior or that disruptive behavior for the reason for referral? If the referral reason is like increasing functional communication, then we need to be looking at, are we increasing functional communication? Is that are we meeting the reason for the referral that they came in for the first place? So it's really, really important to think like outcomes-based care can really be individualized care. And I think it is individualized care because we're looking at saying like, are we making a positive difference in the areas that are important to them?
I gotcha. And now we've kind of gotten at this question a little bit, but let's go ahead and zero in on it. A lot of things that we've talked about so far, get at the idea of personalizing care. So then how does outcomes-focused care dovetail with this idea of personalizing care? Lindsay, why don't you
Yeah,
go and lead us off?
I mean, really that goes into what I was just speaking about, is like thinking about, I think outcomes-based care really is personalized care, because we're ensuring through evaluating outcomes, we're really wanting to ensure that we're having a positive impact on the individual. I think it's really important for us to be thinking about, if an individual is coming in, like I said, where their primary area is communication, which for young children on the spectrum, the majority of the time, that is the reason why I am seeing families come in for referral for behavioral health treatment, is they're just like, I just want to be able to communicate effectively with my child. So can we effectively do those things? The dangerous behavior example, can we effectively reduce dangerous behavior? And so we need to look at, like, how are things progressing? Like Kathleen said, not just measuring at the end, because we can't really understand, if we're only measuring at the end, what the progress is looking like intermittently. Understand if we've actually made a positive impact in that potential area. That's why I think many agencies are using multiple different measures to measure outcomes. I know at Catalight we have various measures that we utilize to measure client outcome. We use the Vineland to measure adaptive behavior over time. But like Kathleen said, for some individuals, that may not be the best measure of their progress. So we also use the goal attainment scale. We also use dangerous behavior to measure over time. We use a sleep checklist if sleep is a primary area, because we know that sleep can have a really negative impact on a lot of different areas of an individual's life. And then we look at the individual well-being, and we look at family well-being. We look at parental stress and parental competence. So we're really looking at a robust array of different areas of measuring, like, are we positively impacting this individual's life? Is it leading to a positive outcome for the individual? And in cases where the family is involved too, is it also leading to a positive outcome for the individual? So I think personalized care and outcome-based, or person-centered care and outcome-based care, are really synonymous.
I gotcha. And let's pass it off to you, Kathleen, before we get to the Q&A portion of our presentation.
Sure. I completely agree here. I think outcome kind of based care often is personalized care, right? Because the nature of the kind of beast there is that we're focusing on individual outcomes, which gels really nicely with the idea of personalized care. And I think often that also means that personalized care, often we think about, kind of tying individuals' priorities and their values into their care, right? And this is letting patients and families kind of determine those priorities and focus on things that align with their values. We see this all the time in other situations. We all make choices about our own kind of lives and values and priorities based on maybe not just a recommendation from our doctor about what would be most helpful for us, but also, what we find to be beneficial to ourselves and for other things. So really, we're talking about, allowing kind of learners and families to make the same types of decisions. And I think often now maybe folks make those, decisions by choosing whether or not to engage in certain types of care, right? I think there's certainly individuals that focus on ABA as problematic and choose other forms of care. But often I think some of the criticisms are not actually of the science of ABA, they're of the way that we're delivering that science now, right? So can we kind of open that up a little bit and think about how to do this in a more personalized way so that we're using our science effectively and using data to make decisions in ways that help everybody have access to care in a way that's meaningful to them.
I gotcha. And let's go ahead and transition over to the question and answer portion of the presentation. Quick reminder to attendees that you can still send in questions via Q&A. We'll try to correlate those and get to as many as possible with the time remaining. So let's go ahead and start off with a question about care settings. Is there is there anything that you guys have seen either in your research or in your experience where there are differences between the care settings, such as in school, in home, or versus in clinic?
I can answer first. There was a study done, I want to say like almost 20 years ago now, that was looking at a clinic-based care versus a home-based care. And Salos and Gropner, I think was the article. And they were evaluating both, and both groups made significant progress in their respective areas. The clinic-based model made like a little bit better progress. But it wasn't so significant that it changed like the practice of like whether or not we should be providing clinic versus home-based care. I will say that a benefit of providing the care in home when possible. I know that there are so many factors that go into that where sometimes it is not possible, and that is okay. We can work with that. But the benefit of providing in-home is it's a natural setting, and we can provide, be able to teach the individual, teach the family their respective skill in the setting they're in the most, which is really, really helpful.
Gotcha. Kathleen, do you have thoughts?
Yeah, I can just chime in and add, I think, if we think about like from a research design perspective, it's incredibly hard to hold all things the same and compare those three treatment settings because there are so many variables that are just different in those settings and maybe different in terms of why you would choose to provide services in a particular setting or not. Right. Even if we think about just within a school, there are so many, are you pulling students out? Are you pushing into classrooms? What type of classroom are you pushing into? How old are the students? There are so many variables there that there's not a clear, A compared to B compared to C comparison. I think this gets into types of providers, kind of focus of therapy. But there are certainly examples of good studies in each of those settings looking at outcomes, right? But I'm not aware of something that really compares across care settings and provides a definitive answer that, clinic-based care is always best. So.
I gotcha. Now let's transition to a question that's a bit more practical and operational. And it's about value-based care. Can you guys provide an example of how outcome-based care might be reimbursed to a provider through something that might be called a value-based care arrangement? And if I can be so bold as the host to offer a thought, this is possible and that this does happen in the marketplace, but it's extremely rare. I can only think of 4 specific examples where there are connections between tracking outcomes, measuring progress on outcomes, and some kind of connection to reimbursement. But who wants to, among the panelists, who wants to take that first?
I'll say I definitely don't think I'm an expert in this area. So I want to call that in, first of all. But I think it is possible to be looking at value-based care and outcome-based care because we can be looking at, are we achieving in the care what is important for the individual? And if we can go to a value-based care, we can see we're making effective change in areas that are important to the individual. And so I think there's motivation there to be providing a really personalized, individualized care that is going to lead to that positive outcome. I had another thought, but it just left me. Kathleen, did you have a thought here?
Did you have a thought? We can come back to you, Lindsey, in just a second.
I can chime in. I will say that I agree. Value-based care is really intriguing. I will also be 100% transparent that no part of my role currently requires me thinking about kind of billing in that regard because I am at a large medical center and pretty removed from those conversations. So while I find it intriguing, I don't have a lot of decision-making capacity in that area. But I think it is intriguing. I think the few models I'm aware of tie kind of specific outcomes over time to kind of the funding in the way that goes. I think it can be beneficial as a provider to have more flexibility to make some adjustments to care without having to seek an additional authorization or change in authorization. So I think that can be great in that you can be a little bit more adaptable. The models I'm also aware of require fairly large both payers and a provider that has a large pool of kind of patients with that payer. And so I think it's also maybe key to think about how this would impact providers and clinics that are not large and that maybe don't have multiple sites or multiple locations where they can kind of aggregate data over time. So it's a really intriguing idea. I think it's absolutely something that folks should continue to think about and work on and try. But I don't know that we have like a great example yet of a way to make it work across lots of different settings.
I gotcha. And then just one other thought based on my experience and reportage, it also requires a high degree of administrative and business sophistication. It does place an additional burden on clinicians to actually track very astutely the progress and also the care that's delivered in the first place, and then turning that into something that a payer would actually respect in terms of reimbursement requires that an organization have really good chops when it comes to both their business but also outcomes measurement. Lindsey, did you have any other thoughts on outcomes measurement and value-based care?
Yeah, the thing that was coming to mind for me is just like the idea here that we're talking about one size doesn't fit all. I think maybe the it's true too with value-based care, wanting to ensure that for the smaller agencies, we're still able to they're still able to work and provide care to individuals. So just like one size doesn't fit all in treatment intervention, maybe one size doesn't fit all in how reimbursement works too.
I gotcha. So we had a couple questions on this. So what outcomes and what measures for those outcomes would you guys prioritize?
I can start maybe on this one, and then Lindsey, feel free to chime in. I'm sure I know you have thoughts too. I always focus on kind of essentially goal attainment, right? Like what were the treatment priorities and are we addressing them? So kind of an individualized, asking caregivers at the outset, why are you here and what can we help you with? And then addressing those. Also kind of, looking at some kind of measure of social validity, satisfaction, however you want to frame it, but surveying those things periodically, and then looking at that kind of role of assent, engagement in sessions, something to kind of indicate that the learner is benefiting from these sessions and enjoys being there and finds them meaningful. I think that is possible even with really young children, right? So really looking at kind of are we addressing the things that brought this family here in the first place, right? Are we addressing the reasons they're seeking care? And then looking at something like caregiver stress, family well-being. There's some good standardized measures for things like that to make sure that we're not adding an undue burden for anybody. So looking at kind of, are we making progress on goals? And then looking at that individual satisfaction, kind of well-being, choosing to be there, and then the family well-being. I think that's 4. So right there in 3 to 5.
Yeah, I agree with everything. Those are all measures that we prioritize at Catalight. So we look at family measures, we look at individual and or family well-being. And then like I said, the goal attainment scale, or the GAS, is a standardized way to measure goal progress. So we implement that, and it's been really helpful in standardizing how treatment goals are written. It also speaks to what Kathleen was saying. Those should be a direct measure of why the individual is there. So are we making progress on those individual areas? I think for dangerous behavior, it's really important that we're addressing the dangerous behavior, and so that we have an outcome measure to address dangerous behavior that is standardized in some way. So we can see if we are making effective change in reducing the frequency and or intensity of a behavior that's happening, that's causing disruption to the individual and the family's life. And then we also do use an adaptive measure. We use the Vineland. It doesn't have to be the Vineland. The Vineland is just a really commonly used tool to measure adaptive skills. So I think adaptive measures can also be helpful, like the DP4, whatever it is. If social skills are the area that the individual is wanting to work on, then we should be measuring social skills and looking at how social skills are improving over time.
Gotcha. And Kathleen, there's another question in the chat about other specific outcome measures that have been used in research to try to get a good gauge on intervention outcome studies. What are some other measures that have been used, in those studies?
Sure. I think sometimes you see measures of cognitive functioning. So things like the Mullen, maybe for young children. You certainly see, the DP4 and other kind of adaptive things like that as well. Sometimes we have seen outcome measures tied to kind of presence of autism symptoms, right? Do we see shifts on kind of some of those scales of autism symptoms essentially? And then thinking about sorry, I just lost. Oh, sometimes in terms of behavior too, I think sometimes you see outcomes tied to something like the aberrant behavior checklist, right? Or something that is kind of a standardized measure of some of that dangerous behavior and thinking about some of those things. So I think there are lots of tools available to folks if you're looking for something that is used, but that has been used and validated. So.
I gotcha. Let's going on to two, granted, different, but at least somewhat parallel questions. We had in the chat a comment that on the best predictors or some of the best predictors of children's positive outcomes being things like cognitive ability. Providers can't control the cognitive ability of the children that come into their clinics. So then, with that in mind, what do providers need to do differently to make sure that good outcomes are possible for all patients, regardless of the level of cognitive ability of the children and other issues that the families are seeking help with when they come into the door of a clinic?
Yeah, that's a great question. Absolutely, that's cognitive baseline ability is not something we can control for, but it's something that can inform the intervention and be really helping us understand like what can be the priorities for this individual, what might be realistic for this individual. And again, we can really be evaluating outcomes there. I see a lot of individuals who have autism and co-occurring intellectual disability. Again, speaking to the fact that a lot of times for young children, it's still communication is the primary area that we want to see effective change in. So an outcome to be looking at is, measuring communication. Are we effectively increasing communication over time? Communication can be a plethora of different things. It can be functional communication, which is really just teaching the individual to communicate in a way that people in their community can access easily. For some people, this can be vocal, and for others, it's nonverbal skills, like being able to communicate nonverbally what their needs and wants are. So I think, we can't control for that, but it should inform our practice, and we should be thinking about how are the outcomes like that it is important to measure outcomes over time and ensure that we are continuing to see progress for those individuals, and not just assuming that if they're in intervention for 10 years that they're gonna suddenly be making significant progress.
I gotcha. Let's go and take on a different question. I'll just read this one verbatim. How do families who are receiving high hours respond to the message that they might not need them all? How do you best communicate with them on that issue?
That's such a great question. And I'll be transparent here that the most important time to have this conversation is at the beginning, of intervention, and explaining what the research is showing with hours, that we can make a really positive impact with 10 to 15 hours of intervention per week. And families are honestly thrilled to hear that they can have a whole, continue to support their child and have other aspects of their life that don't have to be controlled by a 30 to 40 hour a week program. More and more, in my experience, I do diagnostic evaluations as well. Families are becoming more aware of this trend and more understanding, at least in California. And then the other one is parent-mediated care, where parents are being offered parent-mediated care, to showing the benefits of that as well. And parents are also thrilled about that, to be able to learn the skills themselves and then go forward and implement those skills with their child. So in my experience, parents have been positive. I will say for parents who have been in treatment for a while and receiving 30 to 40 hours a week, it is a bit different, where there becomes like this expectation that their child needs 30 to 40 hours a week. And so I really think that's a more gentle conversation that should happen between the family and the clinician who's working with them.
Chris, I can chime in and add, this is a conversation that I have relatively frequently with families, because a lot of the programs that where I'm seeing a family, they are receiving what would probably be deemed a lower intensity model. So some folks are just receiving an hour a week of caregiver training. Other folks are receiving maybe up to kind of 10, 15 on the very highest end hours per week. And so, but all of those programs are a research program or kind of a transitional program where families do move out of that program after 6 to 12 months. And sometimes they are looking for a community-based provider, and they're saying that I need substantially more hours. I almost get it from the opposite end of, have I made a mistake by not, looking for more hours sooner? And often I focus with families kind of back on that. What are your goals for treatment, and evaluating reasonably, if you have, 2 or 3 main areas you're wanting to focus on, maybe you want to improve, kind of adaptive skills and communication and behavior, thinking about what goals do you have in those areas, how many hours would it take to make some progress on that, and then really try to really empower families with, let's think about this in a data-based way, right? So how much progress would you like to see? How much progress is reasonable to see, right? We know we can't necessarily take a child who is not communicating and give them a full suite of communication skills in 3 months, and so how do we kind of scale that appropriately, and then making sure you set some checkpoints. After how long are we going to touch base? And if you haven't made this much progress, should we make an adjustment? And what should that adjustment be? What data are we collecting as providers that would inform that for you? I think that transparency around data is really important. And I think it's important to think about for caregivers throughout, kind of their life, and as I'm often with young children, so I'm not usually talking to 2-year-olds about how their graphs look. But if you are working with an older client, empowering them to advocate for themselves and think about, what are my goals, and have some of those conversations and understand the types of information that can help make those decisions is really important.
Gotcha. And then winding down here, probably this is going to be our last question. Since we're talking about outcomes and basing things on data, there is a question in the chat about research around the number of hours, learning units, opportunities, trials on skill acquisition and behavior change, right? So if the focus is on giving people the right amount of time and to get at the right outcomes, what can we look at in terms of what might be typical in terms of the time needed to make positive improvements?
Again, I think that what we're seeing is that as far as like number of trials, number of times to practice the skill, going back to the Rogers study, which is like a multi-sites, like there's 6 different sites. It was a randomly controlled trial. The individuals in their study made just as their 15-hour-a-week program made just as much progress as their 25-hour-a-week program. So I think that's a good indicator. This is also one of the reasons why I'm such a big advocate for parent-mediated intervention, because if we can teach caregivers how to really, like, it's changing how they parent in a positive way. I want to add that I am a parent and I use a lot of behavioral procedures in my parenting. But if we can equip caregivers with these skills, which is very possible, we see that in many research studies, and in practically, that's what I see on a day-to-day basis. They're able to implement these things with their child in each of the aspects of their life, in their most important areas of living. Transitions can be very, very difficult for neurodiverse and neurotypical children. And when I think about like morning routine, coming home from school routine, bedtime routine, meal times, all of these moments are so pivotal, where parents can really be equipped to teach their child new skills, to reinforce the behaviors they want to see more of. And we see that, like, when we can equip parents, children are coming into more and more contact with those contingencies that lead to positive behavior change.
Gotcha. And Kathleen, we're up on time. So do you care to give us a quick thought or should we close out?
Go ahead and close out. I think Lindsay.
Got it. Okay. I want to thank everyone for joining us today for this webinar. I also want to give a special thank you for Dr. Lindsey Sneed and Kathleen Simcoe for partnering with us on these essential topics in autism spectrum disorder care. Please take a minute to share your experience with today's webinar through the survey link in the chat. Your feedback is an essential part of improving our future programming around these types of webinars. And please register and join us for our next webinar in our series with Catalight titled Differential Diagnosis to Personalized Recommendations, One Size Doesn't Fit All, early next year. I'm Chris Larson, and we'll see you guys next time.